organizations putting on this talk by Dr. Bluestein. I'd like to take this opportunity to welcome you to the event. It's our EDS Wisconsin's first hosted event. EDS Wisconsin was formed just 2 months ago in April of 2017. It was myself, Tammy Kozlob, who was in the back corner of the room, and another individual are the co-founders of the organization. We've come together with the mission to provide support and resources to Wisconsin patients and medical professionals about Ehlers-Danlos syndromes and related conditions via education and research. We are currently seeking our 501c3 tax-exempt status. We don't currently have it, but we are partnered with another organization by the name of EDS Wellness, who is allowing us to work with them so that you can make tax-exempt donations to EDS Wisconsin in the meantime. So at any point you're interested in helping EDS Wisconsin fulfill its mission and move forward, please get in touch with myself or with EDS Wisconsin on our Facebook page, and we can talk about how we're going to facilitate that and make it happen. Also, the other sponsor of this event is Priority Physical Therapy. I'm sure a number of the people in this room may be familiar with them. They are one of Wausau's premier physical therapy clinics. They were founded in 2007. They have been around for a while, and they do a great job. The Priority Physical Therapy is not only a sponsor, but is very integral to making this event happen. Heather Kepitz, who was one of the owners and founders of Priority Physical Therapy, brought Tammy and Dr. Bluestein together. Made the introductions, and we all hit it off very well. We have the same desires, the same mission, the same goals. So Heather brought us all together, and thanks to her, and she'll be up here in just a moment to talk a little bit about Dr. Bluestein, this event was made possible. Now, I do have one statement that, according to the legal folks, I need to read. So I'm going to read it verbatim, and please bear with me. This program is for educational purposes only. All contributors, including EDS Wisconsin Incorporated, Linda Bluestein, Tammy Kozlob, Steve Srzinski, EDS Wellness, EDS Network Cares, and anyone making recommendations cannot be held responsible for misinformation, misconduct, or malpractice. This presentation is not a substitution for medical care or advice. Specific questions cannot and will not be answered, but general education questions can be asked. So, without further ado, I'm going to hand over the microphone to Heather Kepitz of Priority Physical Therapy.
All right. Thank you, Steve, for the introduction. That was very kind of you. I too wanted to say thank you to both Steve and Tammy for all their hard work bringing EDS Wisconsin to fruition. Without it, we wouldn't be here tonight. Tammy particularly had this dream and this vision and this passion for years. I can testify to that myself. And without her, really, she's the catalyst. None of us would be here tonight. So thank you, Tammy. I'm a physical therapist. I've been a physical therapist for about 15 years, and that's really why I'm here tonight. I introduced Tammy and Dr. Bluestein, as Steve has mentioned. But my role with EDS really also comes down to my role as a physical therapist. And what I've been asked to talk about is just briefly a little bit about where that fits in this evening. And many people realize and understand that physical therapists work with pain. And the difference between what I call stereotypical or traditional orthopedic physical therapy is that much of the time we know what the cause of the pain is. There's been an injury, there's been an accident, there's perhaps a degenerative condition like osteoarthritis that may be leading to some of the difficulties that the patient is having. That's not, unfortunately, always the case. And some of us take on a bit more of the complicated cases where the patient still has pain, but there is no known cause, or at least they haven't received that formal diagnosis quite yet. And that's really where we fit in, and where I ended up being invited here to introduce Dr. Bluestein. It's through my practice that I met her and have come to understand her journey. She has asked me tonight to reveal a couple of personal details because she's not only very well prepared to speak with us with her professional credentials, she is also an individual who has personally been there through this process. And I'm flattered to have been invited to share some of these, and with her permission, I am allowed to disclose some of these details about her journey. Dr. Bluestein has been my patient on and off for several years. We met upon the referral of a colleague of mine who had been working with her, and he identified some of the more atypical presentation in some of the persistent pain conditions that exist, and thought she may be a good fit for some of the services that we provide at our office. Over the years, I've had the opportunity to work with Dr. Bluestein on a number of her injuries. Her own recurring persistent pain met much of the time without explanation. In her own words, she has described it as a search long and hard for answers. And I call that the why and the what. The why do I have this pain? What is it? What's it called? What are we going to do about it? Although most of the time we worked together, we didn't have the why and the what. I fit in with the how. And that's where she's got now a lot of her own experience in how do I live with this? How do I manage it? How do I get back to my life, my work, my home, and my quality of life? Regardless of whether this has been named yet, whether I know what this is yet. So ultimately, she did get a diagnosis. About 5 years ago, Dr. Bluestein was diagnosed with EDS. Was also identified to have a tar-left cyst. So she got the why and the what, but she's also mastering the how. And it's because of that personal journey and that personal history that she's uniquely qualified to talk with us tonight. She has been there. She's been a patient. She is continuing to live with and master the art, so to speak, of living with this pain and yet still having a quality of life. So she can empathize with all of us out here who may have some of these persistent pain conditions, whether it's EDS or others. Fortunately for us, she has chosen to take that personal journey and apply it and combine it with her professional expertise as a physician, and more importantly as an anesthesiologist who is uniquely positioned to be understanding pain and pain pathways and pain management. She is a distinguished physician of greater than 25 years, and that's about all the amount of time I'm allowed to disclose. She's been a physician for greater than 25 years. Some of that has been in private practice, some of that has been as a locum tenens physician, which for those of you who are unfamiliar with what that means, and sorry if I oversimplify this to the physicians in the room, but essentially, in my mind, it's basically a perpetually on-call physician. There is no home base, there's no home office, there is no home hospital or home clinic. They're perpetually on call to a variety of facilities and are essentially living out of a suitcase, living out of a hotel to be at a moment's notice available so that perhaps an entire OR of patient surgeries don't have to be canceled because the anesthesiologist on staff is absent. And so that's the type of service that Dr. Bluestein had been providing for some time. Unfortunately, that lends itself to some very unpredictable routines, irregular sleep habits, irregular activity, and ultimately a difficulty with your own self-care and caring for yourself. That would lend itself to strain on any healthy individual, but particularly difficult for someone who is dealing with her own personal journey with persistent pain. And I know after much consideration, she did arrive at a difficult decision to reduce her time in the OR and ultimately really reduce her time as a locum tenens, which again, to our advantage, to everyone here and listening, she now is exclusively focusing her efforts on what we're here to talk about tonight, and that's the persistent pain syndromes and conditions. She is now spending her time educating others and evolving all of our understanding about the treatment of and management of chronic pain conditions, including EDS. She's serving as the Assistant Professor of Anesthesiology at the Medical College of Wisconsin, here at the Central Wisconsin campus, teaching the next generation of physicians how to diagnose and become aware and treat patients with these conditions, more awareness of pain. She's, of course, director there at the Healers Art program. She's serving as a medical consultant to the EDS Wisconsin group, as well as another nonprofit called Chronic Pain Partners. She's a medical advisor at the Woodson YMCA for an active older adults program. She's here tonight and does other public speaking events to educate us all on pain issues, wellness issues, as well as the drug abuse epidemic. She is an author, contributing to our medical literature in peer-reviewed medical journals, most recently to be published next month in the Topics of Pain Management, on an article that's particularly near and dear to me, which is pain management and hypermobility disorders, frequently missed causes of chronic pain. She is not only passionate about helping the up-and-coming physicians, patients and public awareness, but current physicians and their own wellness, serving on a committee at Aspirus here in Wausau, addressing physician retention and burnout. So I am very excited to present her to you tonight. The future is very bright. She intends to continue writing, speaking, teaching, and has also got a goal of developing formal continuing education for physicians and other medical professionals on this very topic. So it's my pleasure to introduce our guest speaker tonight, Dr. Bluestein.
Well, thank you so much, Heather, for that very kind introduction. And thank you so much to Tammy for all of your hard work. Oh, there she is. I didn't know where she went. Moved. And to Tammy for all of her incredible work with EDS Wisconsin. And her passion is really just, oh, that is really touching, really remarkable. And a lot of patients have already been helped by her educational efforts that she's doing with EDS Wisconsin, and many more will be in the future. And it's great for everybody to be here. I really appreciate a diverse audience. We have lots of medical professionals as well as patients. So thank you so much for listening. This program, as Steve alluded to, is an educational program. This is not for medical advice. And in particular, we're talking about persistent pain. So I don't want anyone to take the advice or the information that we're going to talk about and think that it applies to a new or acute problem. So this is information that I'm going to share that I learned through my own journey. It may or may not work for you. Hopefully it will be useful, but it is something that, again, not to be for an acute situation. So this physician, Dr. Dan Claw, is kind of the one who got me started on all of this. He is an anesthesiologist, and he is the director at the University of Michigan. He is the director of the Chronic Pain and Fatigue Center. And one night I was on call in Chippewa Falls, 2013, and it was quiet, and I was in the call room, and I was playing around on my computer, and I came across a YouTube video by him, and it was talking about persistent pain and what happens. In particular, he was talking about fibromyalgia patients, and is it all in their head, or what exactly, why is persistent pain so difficult to treat? And it was amazing to me to see, when I was looking for the reference again, to see how many views that there were on this video, because again, it's an educational, lecture format, and the highest rated YouTube videos are usually 3 to 5 minutes long, and this is an hour and a half. And his video had 109,000 views, which is pretty impressive for an educational type program. And so we're going to talk a little bit about the pain neuroscience that he presented in that program and that he's studying at the University of Michigan. So we're going to talk first about some of the conditions that this information is most useful for, and a little bit of the pain neuroscience behind those conditions, and then go over the 5 tips and leave some time at the end for questions. So who here has heard of joint hypermobility disorder or Ehlers-Danlos syndrome? Just about everybody. Okay, good. So then maybe you also know that we no longer use those terms. Now we talk about Ehlers-Danlos syndromes and related disorders. As of March of this past year, the International Consortium redefined the criteria that we use to now diagnose Ehlers-Danlos syndromes. And it's plural. There are 13 different subtypes of Ehlers-Danlos syndrome. And the most common type is the hypermobile type. About 80 to 90% of patients that have Ehlers-Danlos syndrome have the hypermobile Ehlers-Danlos type. And now they have made the criteria for hypermobile Ehlers-Danlos much more discrete, much more rigid. So a lot of patients that were previously diagnosed with joint hypermobility syndrome no longer fall into the diagnostic category of hypermobility Ehlers-Danlos. And so they have created a new category, hypermobility spectrum disorders, which is basically patients that have hypermobility and they have symptoms, but they don't fall quite into the category of hypermobility EDS. But there are many other conditions that we're going to talk about tonight, or this information, I should say, is relevant for patients with fibromyalgia. It's relevant for patients that have complex regional pain syndrome, irritable bowel syndrome, post-amputation pain, myofascial pain syndromes, diabetic neuropathy, and headache. What we're going to be talking about tonight is relevant to all of these different conditions. But we're going to discuss 4 important concepts before we go into the 5 tips. And the 4 important concepts are, number 1, the difference between acute pain and chronic pain. And then second, we will talk about nervous system sensitization. Then we will talk about neuropathic pain, and last we will talk about neuroplasticity. So why do we have pain? We need to have pain, actually. We are wired to listen to pain. When we have acute pain, our body is telling us that there's a problem and that we need to do something about it. So, for example, you stick your finger in a hot flame and your brain immediately knows you're putting your finger in a flame, please move your finger or else you're going to suffer a more severe injury. So with acute pain, it's a much more one-to-one relationship between the amount of damage and the amount of pain. And there are actually people that are born with congenital pain hyposensitivity. And those people die younger than people who are able to sense pain normally. And if people have a stroke and they have loss of sensation on one side of their body, they often have very severe injuries on the hyposensitive part of their body, as well as infections and things of that nature. But what happens when pain becomes chronic or persistent, it actually becomes a disease unto itself. And with chronic or persistent pain, the pain is actually no longer a symptom. It's actually part of the problem. Because what happens is the alarm system is actually broken. So with chronic or persistent pain, the alarm system is no longer functioning properly. Chronic or persistent pain itself is a disease. It is not a moral failing. It is not a weakness. It is not a choice. But it is also not hopeless. And you might wonder, well, why use terms like persistent pain or chronic pain? Why are you using them kind of interchangeably? They are pretty much interchangeable, but I like to think of persistent pain rather than chronic pain because to me it feels more hopeful. And for me, with my personal journey, a huge, huge piece of this was restoring hope. And part of that, watching Dan Claw, Dr. Claw on the YouTube video, was I felt like I was getting some hope back. And so that is what I'm hoping to do for other people, is to make them feel more hopeful. And Dr. Caswell, a very good friend of mine, is a consultant and assistant professor at Mayo Medical School, and she saved my life not once but twice. Dr. Caswell, who very appropriately received the 2016 Mayo Distinguished Educator Award. She is board certified in both anesthesiology and pain medicine. We trained together. She was a year ahead of me in residency at the Mayo Clinic, and I called her a number of years ago when I was having this horrible sciatica and I had the Tarlov cyst. I kept going to see different doctors and everybody said, no, it's not the Tarlov cyst. Yes, we see it on the MRI, but that's not the problem. And I finally called her. In hindsight, why didn't I call her sooner? But I finally called her and I said, you know, what do you think? I explained kind of what was going on, and she said, yes, that definitely could be part of the problem. Years later, when I had CRPS, she helped me out again and got me over that hump. So Dr. Caswell has also been a wonderful resource for me. She helped me understand the huge relationship between what is going on in our brain and in our head and how we feel in our body. And she helped me in so many ways. And one of the things that she had explained to me in the beginning was pain begets pain. Has anyone here ever heard that phrase before? Pain begets pain? I hadn't heard it either. And even though I had trained as an anesthesiologist, I had not heard that phrase. And now I understand a lot more about why that is. And I didn't understand when I was having especially my Charlotte cyst problems, why I hurt all over really. And she was the one who really explained this to me. So we're going to talk a little bit about nervous system sensitization, or the centralization of pain. And so what happens when we have a tissue injury, we have release of chemicals in our body that actually sensitize us to future pain. Risk factors for nervous system sensitization include genetics, persistent pain, neuropathic pain, and actually the use of opioids. So if you have, I should back up a minute. So if you have persistent pain, what happens is you get more and more release of these sensitizing chemicals, and that's when the nervous system sensitization is more likely to set in. And we can actually see evidence of this on functional MRI. When patients have these type of centralized pain syndromes, whether it's fibromyalgia, EDS, CRPS, irritable bowel, there's a list of interstitial cystitis. There's a very extensive list of problems that involve centralized pain. And we can actually look at the brain on functional MRI and find increased connectivity in the areas of the brain that increase pain transmission, and the areas of the brain that are anti-nociceptive or anti-pain, those areas show decreased activity. So I started trying to think about how to best explain this in a relatively condensed way, and I started thinking about like if you were wearing armor. And basically, if we think of the fact that our nervous system normally starts out with intact armor, and you get a little injury here and there, but it just bounces right back off. So you get a little, you stub your toe or some other little scratch or scrape or whatever, and it's going to bounce right off. But let's say you get a bigger injury. Let's say you break your wrist, okay? So you're going to get a little bit more of a clink in your armor, but it's probably not going to be that big of a deal as long as it heals uneventfully. However, if you break your wrist and then you have a neurologic injury, now you're going to have more of that release of those sensitizing chemicals, and it's kind of like the armor is eroded from the inside out. And now all of a sudden you hurt all over. So this is work. So if you think about the brain and the spinal cord as being, that's the central nervous system, and then the rest, the blue, is the peripheral nervous system. We can actually have sensitization at either the level of the central nervous system or the peripheral nervous system, or both. And once nociceptors, which are pain nerve cells, once they're activated, the nervous system set point becomes lowered and the pain can become centralized. And has anyone here heard of allodynia? I expect the physical therapist in the room to raise their hand. Okay, anybody else heard of allodynia? Okay, very good. So allodynia is when things that are normally not painful at all become painful. So, for example, I had allodynia, and any little touch to my hand was very, very painful. And if you have allodynia, for example, in your foot, then the bed sheets touching your foot are excruciatingly painful. I see some knots. And that is our nervous system being dramatically altered because of the pain processes and the chemicals that are being released throughout our body. When our central nervous system is sensitized, we get what's called hyperalgesia. And hyperalgesia is when things that are normally a little bit painful become very painful. So something that might be a little pinch or something like that now feels like a stabbing type sensation. And this graph shows, if you look on the x-axis and going from a low stimulus intensity up to a high stimulus intensity, and I promise this is, I think, the only graphic here. And on the y-axis, we go from a pain score of 0 up to a pain score of 10. And this curve on the far right is the normal pain response. So at a low stimulus, you have no pain, no pain, no pain, no pain, no pain. Now all of a sudden, yeah, you're starting to feel it, and the pain level gets higher and higher as the intensity gets greater. So that's the normal pain response. When the nervous system is sensitized, and when you get central sensitization, what happens is the curve gets shifted to the left. So in this example, this is specifically referring to fibromyalgia, but it could be any centralized pain state. So now all of a sudden, at this level where before there was no pain, there's actually pain. So in this condition where there's pain amplification, now a hug, or the sheets touching your foot, or the blood pressure cuff going up on your arm, now is suddenly painful. And as you go up higher on the curve with this pain amplified response, now you have things that are excruciatingly painful that would only normally produce a very small amount of pain. So we know that the nervous system is regulated, and we know that there's actually something called exercise-induced hypoalgesia. So there's hypoalgesia and there's hyperalgesia. Who here has heard of exercise-induced hypoalgesia? Excellent. Okay, very good. So exercise-induced hypoalgesia refers to all the wonderful endogenous chemicals that are released when we exercise. And this is part of the problem when we get chronic pain, because often we stop moving. So we no longer have these wonderful chemicals that actually help us to have a higher pain tolerance. So that's part of the whole process. So when we exercise, we actually become less sensitive to pain. Neuropathic pain. So this is another important concept when it comes to thinking about persistent pain. This is different from centralized pain, but they are very closely related. So when we have neuropathic pain, the pain is actually inside the nervous system. And the pain is difficult to treat. And if you have neuropathic pain, that increases your risk of central and or peripheral sensitization. And a common cause of neuropathic pain is post-amputation pain. So unbelievably, about 90% of patients who have an amputation have pain after the amputation in the limb that is no longer there. So we know that pain is very complicated. How can you have pain in a part of your body that's no longer there? That's when we know that the pain is actually inside the nervous system. This is one of many conditions that causes neuropathic pain, but it's a very clear one. How do you treat pain in a foot when the foot doesn't even exist anymore? Neuropathic pain is a situation in which we often will use what's called multimodal analgesia. One drug is not going to take care of neuropathic pain. I wish that it did, and maybe a few years from now, maybe we will have something. But right now, we need to use several different types of drugs usually in order to treat neuropathic pain. And these are some of the examples of some of the drugs that are currently in use for neuropathic pain. Tricyclics, gabapentinoids, which is gabapentin and pregabalin, SNRIs, SSRIs, or low-dose naltrexone. So there are several types of pain. Nociceptive pain is when you have tissue injury and you have pain, a more clear-cut type of picture. You sprain your elbow, or elbow's not the best choice for a sprain. You sprain your ankle, or something like that. Neuropathic pain is when you have damage that's actually inside the nervous system, and centralized pain is when it's related to pain processing within the nervous system. With centralized pain, we can also get fatigue, sleep disorders, memory, and mood problems. And this also responds less well to surgery and procedures. So it's very important to identify patients that have centralization as a cause of their pain, because we want to be more conservative when it comes to considering surgical options. The fourth important concept is neuroplasticity. And this is the wonderful ability of our brains to create routes and to strengthen neural connections. So whenever we do some type of mental activity, whether it's something that we think or something that we do physically, we strengthen that activity in our brains. So for me, I've fallen in love with Zumba. Every time I go do it, I strengthen those connections, and it gets more and more fun and easier because those connections are strengthened in my brain each time. And this is something that we can use to help us. So this is a very important concept. And Hebb's law, neurons that fire together, wire together, is a very important and kind of succinct way to just think about neuroplasticity. We used to think that the brain would stop developing at a certain point, and that was it. And as adults, all we could do was deteriorate. Thank goodness, we now know that that's not true. So the guiding principle here is that pain is not equal to damage in a chronic pain type situation. Pain equals damage plus processing in the nervous system. And so one of the things that we can do, in addition to, again, this is a supplement to the treatment that you're getting individually, this is something else that we can do. We can work with changing our thoughts and our actions to change how we feel emotionally and how we perceive pain. So about 6 months ago, I attended the National ASA conference where about 100 countries were represented, and there's about 20,000 anesthesiologists. And I was sitting in a lecture by Dr. John Rawlinson from the University of Virginia, and I was sitting in the audience of about 2,000 people, and all of a sudden I realized that he dispelled 2 myths for me. And one was, at that point I knew that there were things that I could do to make myself feel better. I knew that there was more in my own hands. But a lot of what he was explaining, the centralized pain, really just hit home for me even more. It made me feel even more hopeful. But even more so, listening to him speak, I realized that the other thing that I felt a lot of people might be thinking, patients that are in pain, that healthcare professionals and scientists don't necessarily believe that they're in pain. And that's not true. They are working very, very hard at coming up with better solutions. We don't have a cure right now. There's no miracle drug, but we have lots of treatment options available. And these things that we're going to talk about tonight are things that we as individual people can do to help ourselves feel better. So now we're going to go on to the 5 tips. And the first one is regarding our expectations. So expectations have a lot more to do with pain than what we might think. When I looked on PubMed at just put in expectations in pain, I got a result of thousands of articles just dealing with expectations in pain. And there was a very nice study done looking at expectancy of these volunteers in terms of the effect from a strong intravenous opioid. And so they took these healthy volunteers, and it is a within subject design. So say I'm one of the subjects. One time they're going to do it one way, another time they're going to do it a different way, and then a third way. So this drug, remifentanil, is a very potent IV opioid. And one time that they give it to me, they're just not going to tell me that they give it to me, but they're going to give it to me. Another time they're going to tell me in advance, we're giving you a medication that's going to make your pain worse. And then another time they're going to give it to me and they're going to tell me that my pain is going to be better. Anybody have any guesses as to what happened, what they found? And not only did they record pain scores, but they also looked at functional MRI data as well. And what they found was that expectations greatly influenced visual analog pain scores and functional MRI findings. So in the patients that had no expectation, they just gave them the drug and didn't tell them they were giving it to them, that time the pain rating did go down, and it went down, a remarkable amount. But when they told them, we're going to give you a very potent pain medicine, you can see that the pain score went down considerably more. It went down dramatically more. And not only that, the parts of the brain that are involved in more resilience to pain were actually highlighted in the person's, in the subject's brain. And when they were given a negative expectation, they were told this medicine is actually going to make you feel worse, then they didn't even get any benefit from the IV pain medicine. They still got the IV pain medicine, but their expectation actually completely abolished that effect of the IV pain medicine. So I found this quite interesting because of the fact that this is not even a chronic pain study. This is more of an acute type scenario. So we know that our expectations have a lot to do with how we feel. So other ways that I feel, for me personally, that this has been beneficial, I did have people tell me, okay, so you have Ehlers-Danlos, so what? There's nothing you can do about it. But in the meantime, I realized, listening to Dr. Claw and my very dear friend Dr. Caswell, among others, that even though there's no magic pill, there's no fancy cure, that I realized that there were other things that I could do, and that by changing my mindset, that would help a lot. So changing our expectations helps a lot. And to have the expectation of zero pain often would set me up for disappointment. So instead, I would look for those little incremental changes and focus on function. And I did keep a journal, especially when I was recovering from my Charles cyst surgery. I kept a journal, tried not to obsess about it, but I would write down how far I could walk, and that kind of thing. And I didn't really realize until I looked back that I was actually improving, and so that was helpful to me to see, because after my surgery, first I was swimming in the pool and then walking on the treadmill, and I was walking really slowly, like 0.9 miles an hour, and I had been previously very, very fit. So looking at those tiny little changes was very encouraging and really helped me a lot. The second tip is practicing moderation. So as they would say at Mayo, do, don't overdo. And this is what I was told when I was visiting there in the pain clinic, which was definitely not something that I ever had planned on doing. It was personally pretty devastating to go back there as a patient, because when I was working there or going through my training as a resident and seeing patients in the pain clinic, I felt that it was such a difficult place to be as a patient. So it was, psychologically, it was kind of tough to go back there. But it was very helpful because they also taught me a lot of tools, and Dr. Timothy Lamer was very helpful to me because he explained to me that it's very important to do activity and you need to move, but don't overdo it. Well, it's easy if you have a day where you're feeling good, then you try to do too much, and then the next day, now you are able to do nothing, and then that gets discouraging. So doing without overdoing, and it's different for each person, and that's where the journaling often is helpful. And this is also true for, I would say, online research, because it's easy to start looking things up, and I think I've diagnosed myself with pretty much everything I've ever looked at, and it's very easy to do that nowadays online, and it's easy to lose a lot of time and to be on the computer for hours and not even realize that you did it. So even when it comes to things like research, it's important to practice moderation. Also, it's important to think about how to talk to your doctor, your nurse practitioner, your physician's assistant, so that they will listen. They're busy, they have a lot of other pressures. It used to be the doctor and the patient in the room, and now it's the doctor and the patient and the insurance company and all the regulatory bodies and the electronic medical record. So there's a lot of things going on, and it's your choice as to whether or not you take their instructions and whether or not you follow their advice, but you're there to get help from them. So it's important to go in with an attitude of, I want to get help and I'm going to listen, because sometimes patients actually come in with an antagonistic attitude, and when they do that, they're only hurting themselves, because we kind of mirror each other's emotions, and going in with an antagonistic attitude only hurts yourself. And likewise, you sell yourself short if you go in with a closed mind, if you already think that you know what you have, what you need. And most physicians, nurse practitioners, physician's assistants that I know are happy to have a conversation with you and have a two-way conversation, and will respect. If they tell you, I think you should do A, B, and C, and you say, okay, well, I think that I would like to do A, but I'm not going to do B and C, but you have this conversation respectfully, because you can certainly disagree without being disagreeable. That is an approach that I think is more likely to get your healthcare professionals to listen to you effectively. And you don't want to waste your own time either. It's also important to get enough sleep. The effect on sleep and pain is actually bidirectional. So when you have inadequate sleep, the pain gets worse. And when you have worsened pain, then the sleep gets worse. So making sleep a priority is important. And it's very difficult to do, but in terms of sleep hygiene, not using electronics or wearing those funky orange glasses before your last couple hours before you go to bed is often helpful. And the last tip that I want to mention tonight is to stay in the moment and try not to think too far ahead. There's lots of very good data that shows that patients with Ehlers-Danlos have a much higher risk of anxiety. And when we have anxiety, we tend to think about a lot of things in the future. And some of that thinking can be beneficial if it helps us to plan and that kind of thing. But when it just becomes worry and we start to ruminate, then it's not helpful anymore. And practicing mindfulness can be very, very helpful. Who here has heard of John Kabat-Zinn? Okay, very good. So he has written many, many books, and he did this study that was a long time ago, 1982. Some of you probably weren't even born yet. And it was a relatively small group, and he's written many, many articles and books. And during this study, he looked at patients with low back pain, headache, gastrointestinal pain, a variety of neck pain, and a variety of different conditions. And he put them through a 10-week program of mindfulness training, and basically dissociating your thoughts from your trying to be detached about your feelings in your body, and living in the moment, being mindful, not mindful. And the results were really very, very impressive. 65% of these patients experienced a greater than 33% improvement in their pain and functional capacity, and 50% had a greater than 50% improvement. So getting back to Dr. Claw, in this article that he wrote, it's a continuing medical article that he wrote in the Mayo Clinic Proceedings in 2015 called Fibromyalgia and Related Conditions. The pre-best studied non-pharmacologic therapies are education, cognitive behavioral therapy, and exercise. And all of these have strong evidence for use in fibromyalgia and other centralized pain states. So these three therapies are ones that are very, very important to keep in mind. And in fact, there are so many studies on those three factors that oftentimes the number of patients that this has been studied, it exceeds that of drug therapies, especially when we look at function, which is really what we should be looking at. We should really be focusing on function and not visual analog scores. And another advantage to these treatments is that they often result in sustained improvements. Access and adherence are challenges with these therapies, but these are things that we can work on. So the way I view it was a number of years ago, I was in this chaotic state. I feel like I had pain brain. All I could think about was pain. All I ever talked about was pain. And it was ruling my life. And through my individualized medical care and things that I learned myself, and very, very slowly, it takes a lot of time, I feel that I'm now in remission and am living a much better quality of life. I still have pain, but I'm living a much better quality of life, and pain does not rule my life anymore. So the 5 tips are resetting your expectations. Oh, and I didn't change this. I changed some of the tips, but I didn't change the summary slide. So one of the other things that I had included originally as the 5 tips was allowing yourself to grieve. And this was important for me because when I first hurt my knee, which then led to my hurting my back, and knowing that I had the Charlotte cyst, prior to that, I was actually training for a bike race, and I was in the best shape of my life. I was so incredibly fit, and this was devastating to me. I was working full time. I was in fantastic shape. I felt like I was invincible. And I fell off my bike, did a lot of things to my knee, and ended up that was the last time I ever rode a bike. And I finally had to give myself permission to grieve, that I don't ride a bike anymore, and I no longer go skiing. So I had to really process that. And changes in my work status have also been really challenging at times. I really, it takes time to process those things. But you need to allow yourself to grieve those changes and get to the acceptance phase. I was in denial for a very long time. It was years before I let my husband sell my bike. And my skis. And it's important to practice self-compassion and not self-pity, because it's easy to think, for me, Dr. Stephen Benson had helped me a lot, and one day he looked at me and he said, "Linda, you're way too smart to play the victim." And that was kind of, like a dagger, but he was right. I was feeling like a victim, and we all have our stuff, And I'm no different than anybody else. We all have things that we have to deal with in life. And so it was important to not practice self-pity and instead be compassionate with myself. We often tell ourselves things that we would never tell a friend. We beat ourselves up and we are sometimes very cruel to ourselves. And even though I know that I'm short on time, I just want to mention one other thing that was originally in the 5 tips and then got taken out. Find the joy. So for me, I've always loved to dance. I've loved to dance my whole life. And I can't do ballet anymore, of course, but finding Zumba was wonderful for me. I have to modify pretty much everything that we do, but it's something that is just, it brings me so much joy and so much pleasure. And so for me, finding something that brought me joy helped me to, instead of just trying to avoid pain, helped me to feel like there was something that I, could actually find enjoyable. So in summary, pain itself can become a disease, but we each can take steps to improve our quality of life. We are not hopeless. And there is hope for even beyond the things that we talked about today. There's all kinds of things being studied. Scientists are making progress all the time. They're with neuroimaging and things like this. There's all kinds of new developments. There's new drugs that are being worked on, and there is hope. And that's a very important piece to keep that hope alive. So I believe Tammy, if she hasn't already, is going to pass out evaluation forms. And for people that are watching online, we would like your feedback as well, because EDS Wisconsin, Tammy in particular, Tammy and Steve are very, very passionate about helping people with EDS and other painful disorders, and we would like to know if you found this helpful, and so we would love to get your feedback. Questions?
Does anyone need a form? Yeah, and I apologize. I was going to bring note cards for people that have questions, but we did not bring the note cards.
So we'll just raise our hand the old-fashioned way.
Yes, so the old-fashioned way.
Questions? Yes?
Do you think it would be helpful if instead of giving all these kind of diseases the title chronic, because as soon as you say that, it becomes hopeless. I don't care who you are.
Right.
When you think that there's hope to get better, then you react differently. But you go through that whole phase and it sets you up on all these particularly rare and autoimmune diseases where it's chronic, it's forever, you're never going to get better. I mean, and the things the doctor says to you set you up. I mean, yes, the pain is horrible. Yes, I've been working with other issues, but when you say that word, you're just mentally so set up. Is there a way to get doctors to stop using such horrible, fatalistic stuff? I mean, you just feel hopeless.
Right, I completely agree with you, and that's why my goal with this part of my career, with being a consultant for a couple of different nonprofits and also doing education at the medical school and doing continuing medical education, my goal is to bring healthcare professionals and patients, improving the communication between them and being able to convey things like that. Do you realize when you say this to a person, because I have people say to me, well, whether you have EDS or not, there's nothing we can do about it. I had somebody say to me, well, whether you have a Tarloff cyst or not, there's nothing that can be done about it. And you're right. You leave there thinking, it's so depressing. That's exactly right. And that's a good point about the word chronic. I don't know that we're going to change necessarily the way things are, because there's ICD-10 codes that are, but at the same time, I think that this is where I really want to work to bridge between patients that are experiencing really significant conditions that have so severely affected their life, and getting them in touch with the right resources so that they can feel better, and educating physicians and nurse practitioners, family practice doctors, physical therapists, how to communicate with patients in a way that is helpful and not harmful. So I think that's a great goal for us to have, and definitely, I
I
appreciate
think
you
you want to
pointing
be
that out.
lied to, but I think
Right.
you want to feel like there's some kind of hope, not like,
Right.
you can do this, but there's nothing else we can do and this will go on forever.
And that's why when I had my paralysis surgery in 2011. So I had already had my surgery 2 years before I saw that video by Dr. Claw. And I remember like literally what call room I was in, where I was when I started watching that video. And I thought, like it was really an aha moment, like, oh, okay, so that, because I had already had the surgery and I was doing better than I had been, but I still had a fair bit of pain. And for me, I still, at that point, when I watched that video from him, I still had the idea that pain equals damage. So when I would have the pain, in my mind, I would think, oh my God, oh my God, oh my God, something is really, really wrong, and that made me hurt more, which then made me more bummed out, which then made me hurt more, so it just fed into that cycle. But then I saw that video and that lecture that he gave, and I thought, oh, okay, this explains it, and there are some things that we can do. So I think that's a very good point. I think that this information, in terms of the centralized pain, needs to be spread to a lot more, especially the frontline physicians, the family practitioners, the internal medicine doctors. They need to know that the reason why people hurt with persistent pain states. And just this morning, I wrote to Dr. Claw and I said, just an FYI, I'm going to be mentioning you in this program, and there's going to be people watching on Facebook, so you know you're in Michigan, you'll hear about it. So I was shocked. He wrote back to me within a matter of hours, and I'm going to go out there and work with them so that I can learn more about this centralized pain condition and how we can help people feel better, because that's the goal. We want people to be able to function better, and I think it sounds like you're like me, that, okay, so you tell me that you can't cure me, but you can still work with me in a way that can make me feel like we're working together as a team, and we're gonna, none of us get out alive anyway, right? So the question is, what's the quality of life going to be? So I appreciate that comment and question. So I will keep that in mind when I go to talk to him.
Yeah, it comes down to quality.
Right.
I don't care how long I have, I want the quality
Exactly.
of what's left.
Correct. Correct. Absolutely.
Dr. Bluestein, can I add to that?
Of course.
What
You want to come up here to add to that so that,
Sure.
please?
Whether we can change the ICD time codes or not, in my experience, the healthcare professionals are really using the word chronic more as a definition of it's not acute. It's reached a certain number of months that this condition has been in existence. Chronic doesn't have to equal permanent. And so if we probably can't change that definition, and we're trained to use that word because it differentiates that this didn't just occur last week when you sprained your ankle. You've had this for 6 months by definition, and that doesn't mean 6 years, 60 years. So if we can just change the conversation too, even if we can't change the codes, because there is a defined medical definition that we use of what chronic means. And it probably means something much different when the patient receives that. And here is permanent and non-curable, when we're using it as it's just been here longer than the average situation. So it's not permanent. That doesn't necessarily mean what that means. So,
But you're right, you definitely perceive that way. And in some cases, it is permanent.
In some cases, yes.
but modifiable.
Right, exactly.
Doesn't have to be a static, constant, permanent.
Right, right. Other questions? Yes.
As a physician, one of my hardest problems is figuring out who to send things to, even to just get the patient specifically diagnosed. And is anybody in the EDS community or pain community developing educational videos to just go through all the 13 different kinds of EDSs, go through, so that you can mass educate people like me that I don't know who to send them to anymore. I knew before, but they retired.
Right.
So now you have to find the right person in the area to get the diagnosis or to get the treatment. And it seems to me that video education is going to be YouTube education is going to be the way to go.
Sure, sure. Well, I'm hoping that there will be some there's physicians here in the audience. I'm hoping that there will be some physicians that watch this program, although it's not specific, obviously, to EDS, and we didn't discuss at all the new classification that came out from the International Consortium in March. So I definitely think that what you're saying is very appropriate, and I am planning on doing educational type programming to live audiences directed specifically to medical professionals, because to me the big thing is they just need to know to look for it. And I think that family practice and internal medicine physicians in particular are the ones that it would be really helpful, and even the centralized pain information for them to have, and about fibromyalgia and that kind of thing would be very beneficial, because you're not going to come up with it if it's not even at all on your radar. So EDS awareness, or the parent company is Chronic Pain Partners, and EDS awareness, I'm their medical consultant, and they have webinars that have been produced for patients, but they're also at a pretty appropriate level for a lot of healthcare professionals as well. They have about 65 webinars that are available on YouTube, and so there are other programs that are either in place or there are conferences that are held and that kind of thing, and there are some other programs that are in the works.
Yeah, two of the groups that we're working with, there's the EDS awareness, which they have tons of good information on there, like really good information. And then there's EDS wildest. She also just did a video on the new classifications. So that's something that you can look up. And they are supporters of EDS Wisconsin. They're very passionate, motivated people. I mean, they really want to help people with EDS and related conditions. I mean, they really want that. So those are really good sources.
And actually, to your point, so this article that I wrote, what was the title? Pain management and hypermobility disorders, frequently missed causes of chronic pain. Did I get it right? Okay. So this article that I wrote is going to be published next month in the journal Topics in Pain Management, and it will be available for free online. They always have their current issue available for free online. So there's a lot of good information in there as well, and I plan on I already have told a number of local family practice physicians and internists, hey, look for my article, and once it's actually available, I plan on letting people know about that, because that's a free thing, it's fairly concise, and it will give them some information. In there I discuss about the classification and the criteria, and I actually had written the article, I had to completely rewrite it because of the way the timing worked. And I had read an article for 23 years, so writing it twice was kind of painful, but it was worth it. So.
Do you want to take an online question?
Sure.
Quickly? Okay. Scarlett Babe asks, how does pain become a disease?
So pain becomes a disease, so as we talked about acute pain being a symptom of a problem, so I'm just going to back up to acute pain first. So if we use the example of I put my, I'm cooking something and I take the pan off and the flame is there and I put my finger in the flame and it feels hot and I'm like starting to burn my finger, then that's a symptom of a problem, and it's telling my brain, you better move your finger, dummy, or else you're going to burn your finger. Once the pain becomes chronic, though, once it becomes persistent, once it's been there for a while, the pain is no longer an accurate reflector of what's going on in the body. So the actual, so in my example of having a Tarloff cyst, I still have pain that goes down my left leg, but that doesn't mean that I still have damage in my spine and in that part of my nervous system. It's kind of like memory, that it might still be there, and it's not something that I need to, I kind of learned to tune it out to a fair degree and also modify the way I do things. So the pain becomes a disease because the pain is now actually the problem rather than a symptom of the problem. So I hope that answers your question.
Kind of how you say pain begins pain.
Right, right.
So it's time. Thank you so much for doing this. I mean, I'm really hoping that we can reach a lot of people and that we can do more events like this in the Thank you. In about 10 minutes, we're going to do the raffle drawings for the prizes, and that's for everybody that's here. We're having a special, anyone that submits these, anyone who submits these can pick from
I think I should
everything.
come over here so they can, oh, so you can be seen on the camera.
So,
And then we can hear you better.
we're just exiting. So, you can pick from all of the prizes, and we're going to do that in about 10 minutes because Dr. Bluestein really wants feedback. She wants to know, where are we going? Where are you at? How was this presentation? Was it helpful? Because we really, really want to reach people, patients, providers.
Don't be shy.
EDS Wisconsin is focused on Wisconsin because we live here. We really want to reach more people, but we live here. So hopefully we can do what we can in our community. So everybody is always welcome to join any of our online events or anything like that. But